So ibrutinib has been approved by the FDA since late 2013, early 2014 in CLL. And that approval was initially in the relapse refractory setting. The RESONATE study then led to approval in the frontline study in comparison to chlorambucil. And chlorambucil is not a particularly robust type chemotherapy. And so there was a lot of interest to know whether or not ibrutinib compared to a more standard chemoimmunotherapy would be better or not. Bendamustine rituximab, even today, represents probably the most commonly utilized chemoimmunotherapy for patients in CLL. It's not quite as intensive as FCR, but probably represents the first-line treatment option for about 30% of patients in North America. And so this was a 3-arm study which randomized patients to either bendamustine rituximab, ibrutinib, or the combination of ibrutinib with rituximab. There were effectively 2 comparisons. Comparison number 1 was ibrutinib to bendamustine rituximab, and then the second question was whether or not rituximab added anything to ibrutinib. The easiest issue to dispense with first is the addition of rituximab to ibrutinib in the frontline setting adds nothing. So that was something that was very much unknown, and there's really no need for rituximab. Now that doesn't necessarily say all CD20 antibodies are useless in that setting, because there's additional studies looking at obinutuzumab being added to it, but at least as far as rituximab is considered, the addition of that to ibrutinib really doesn't do much. The larger comparison in the study, however, was ibrutinib versus bendamustine rituximab. And there were a number of interesting findings. If you look at the progression-free survival, which was the primary endpoint of the study, both ibrutinib-containing regimens largely beat bendamustine rituximab. So there was a solid victory for ibrutinib in that setting. What's interesting in the study, though, is to really get into some of the subgroup analyses. In CLL, the disease is divided into 2 main categories: patients who have a mutated B-cell receptor, which is favorable, and an unmutated B-cell receptor, which is unfavorable. And for those patients with unmutated CLL, the superiority of ibrutinib was very clean. What's a little bit less certain is in the mutated population. These are patients who tend to get more durable responses to chemoimmunotherapy. And in this population, the progression-free survival was relatively similar. There was a little bit of a difficult finding that I think has been hard to understand or explain, which is that in the first 3 years of ibrutinib, there is a slightly higher mortality rate for patients on ibrutinib. It's not statistically significant, but I think the 2-year survival for bendamustine rituximab was 95%, and the ibrutinib-containing regimens were between 90 to 94%. So very slight differences, but where the controversy in the field may exist is what to do in those older patients who have the mutated CLL, mutated version of CLL. I think that a number of practitioners, thought leaders in the field actually find this to be a very debatable point, and would certainly leave room for plenty of patient discussion.